We start now with part 2 of the lecture of Maryam Kavousi, and she will talk, of course, again about research design, but now related to population and data.
Welcome back to the second presentation on implications of sex and gender in research design. In the first part of the lecture, I asked you to think about the choice of your study design. I asked you to think whether considerations of sex and gender would affect the type of the study design that you would choose to answer your research question. I provided some slides to go in detail into different types of study design and think about it. So, what is the answer now? In study design, it's generally accepted that there is a hierarchy of evidence based on the type of study design, meaning that as we move from case report and case studies to etiological studies to analytical observational studies, including cross-sectional case control and cohort studies, and as we move up to randomized clinical trials, we move up in the hierarchy of evidence. So that's clear. But does this affect your choice of the study based on sex and gender perspectives? The answer is the choice of your study design depends on the research question you want to answer. It depends on your hypothesis. It depends on the type of data that you have to answer that research question and the temporality of that data. When is your risk factor data gathered? When is your outcome measured? And that should define what would be your study design. So the choice of the study design is little affected by sex and gender considerations. So not much. But there are also exceptions to it. Think, for example, of the studies that want to examine a teratogenic drug, and therefore it's unethical to test it on pregnant women. So here is one of those exceptions that sex and gender-specific perspectives come into consideration. Or imagine, again, that because of ethical constraints that are sex and gender related, you cannot choose for a randomized clinical trial, but you have to choose for a quasi-experimental trial. But most of the time, the choice of your study design is not affected by sex or gender considerations. Your research question should guide you. Apart from this, all other aspects of your research design that we will discuss during this second, third, and fourth lecture of this series will be affected by sex and gender perspectives. So having a sex and gender informed consent, informed perspective at every step is important. Now, let's move to study population. You've defined your research question, and now you want to choose a study population to answer that research question. To have a sex and gender-informed perspective, of course, the first step is to include both men and women in your study. But should it simply be division of your sample size in an equal manner between the sexes? So including both male and female in your study in equal numbers? And then you're done? So in reality, it's more than that. So just dividing your samples as equally between the sexes might not be the most efficient approach. So how do we do that? Go one step back. Think about what is the goal of your study. In any study that we do, our goal is to optimize validity, generalizability, and efficiency of our study sample. And in this regard, to realize these goals, there are certain considerations that need to be taken into account. Think about sex-specific age incidence of the disease that you're studying. Think about reproductive stages and cycles that might matter for your study selection. Also think about the impact of gendered social environment. Now I'll show you examples of each. imagine a case that you're doing studies on coronary heart disease. We know that if you look at the different age groups, and as you see in this slide, we know that, for example, if we look at the age range of 55 to 64, the rate of coronary heart disease in men is more than twice that of women. But as we age, and at older ages, look at the category of 85, for example, older than 85, you see that the difference between men and women is not that large anymore. So if you want to study at younger age groups to look at coronary heart disease, what do? Is it efficient to include the same number of men and women in your study? So if you want to maximize your statistical power and make sure you have enough number of events in each group, you might want to include more women in your study if your focus is on younger age groups, or go and choose for a group of women that may be a bit older to ensure the number of events that you need in your study. That's also affected by, of course, aging and longevity. Overall, we know that women outlive men. In European Union, women outlive men by about 5.5 years. Does this affect your study? Think about heart failure, for example. It's an inability of the heart to pump blood and oxygen to organs of the body. If you're doing a study on heart failure, if you're looking at short-term risk of heart failure, imagine 5-year risk, cumulative risk of heart failure, you see that if you look at the category of, for example, 50 years of age, you see that women have a much lower 5-year risk of heart failure compared to men. But we know that women outlive men, they live longer than men, and we know that heart failure is a disease that happens mostly among the elderly. So if I look at a lifetime risk of heart failure, I see that at the age of 50, women do have the same lifetime cumulative risk of heart failure as men have. The risk is about 21% in both groups. So this is also another aspect to have to take into account while you're selecting your subjects for the study. Also, in selection of subjects for your study, reproductive stages and cycles matter. We know that all animals go through a reproductive maturation. The pace, the timing, and the outcomes of this reproductive maturation vary largely between the individuals. Imagine that you're doing a study on adolescents and young adults. So you do need to take into account differences in the pace and timing of puberty. If you're doing a study on older men and women, for example, you do need to take into account variations in gonadal steroid levels. Among men, for example, the testosterone levels go through a circadian and seasonal variation. It can also be affected by physical activity, for example, and age. Among women also, there is a natural variability in sex steroid levels. So you need to take into account, for example, if women are in the perimenopausal stage or postmenopausal stage. You need to know about their menopausal transition. You need to have information on their menstrual cycles if they're younger women. And this all might affect the choice of your subject selection. Also, what comes on top of this natural variability are the exogenous hormones. So women might take oral contraceptives or hormone replacement therapy around the menopause, or men might take exogenous androgens. So this all might matter for the choice of your study selection. Sometimes, depending on your research question, and to limit the effect of these variations in your study, you might want to choose, for example, to study the postmenopausal women only, or the premenopausal women only. So such considerations matters. There are also other aspects that matter. Some of the factors, the physical and social determinants of the disease, might be differentially distributed among women and men in your study. If that happens, that these factors are strongly related to your exposures and outcomes under study, this might distort the results of your study. We'll get back to this when we are discussing the confounders and effect modifications in our lectures, but this is something to be aware of when you're collecting your data. So this bridges me directly to the topic on data collection, that you need to make sure that you collect the data in a way and in such a detailed sex and gender informed manner to be able to characterize the ways later in which exposure, disease, and other factors that are important in your study might be affected by sex and gender. So then a bit about the data collection. What do we need to take into account when we are collecting the data in our study? Imagine an outcome, for example, coronary heart disease, that we are aware nowadays, of course, that there are differences between men and women with regard to disease presentation. So when you're gathering information on the outcome, you have to be aware that men and women might not present with the same symptoms. With coronary heart disease, what we know is that women might present with much more atypical symptoms compared to men. So they might not really present with the typical chest pain, but they might present with atypical symptoms of fatigue, for example, or shortness of breath. And this is important to notice and gather information about because it can it can highlight the ways for you to gain some insight into the pathophysiology behind the mechanisms that are involved, for example, in coronary artery disease in both men and women. We know nowadays that classical obstructive pattern might not be the sole, let's say, pathophysiological mechanisms for both men and women, but among women, other mechanisms might be also as important, including the microvascular dysfunction, for example. So you have to gather the information in a detailed way that allows you to look for differences and similarities. Also, imagine the sex and gender differences in drug exposure. Of course, the differences between men and women can be attributed to different body size or volume of distribution or different pharmacokinetics and dynamics of drugs in both sexes. So that's something also to be aware of when you're gathering the data. Something else to take into account is the considerations in reporting reproductive cycle and phase. For example, in women, if you're gathering data about menopause, you need to make sure that you also gather data about other factors that might affect that menopause. You need to ask, for example, questions about whether the menopause was natural or surgical menopause. It was induced by hysterectomy or oophorectomy or irradiation, chemotherapy, for example. You need to ask if they're using exogenous hormones, for example, such as hormone replacement therapy. And also, you need to take into account that in other influential variables in your analysis, there might also exist considerable sex and gender differences that is required to be taken into account in your data collection. If you're dealing with a study that you need to gather information, for example, about exposure time, you also need to take sex and gender considerations into account. Some of the exposures are very short. Imagine radiation or atomic bomb of Hiroshima. There was a very short exposure time. It might not matter to have a sex and gender informed perspective there, but for a lot of exposures that you study, the exposures accumulate. Sometimes there is a minimum threshold for that exposure to exert its effect on your outcome or disease under study. The dose of exposure, the duration of exposure, the consistency, whether it was continuous or intermittent, and timing of that exposure matters. And sex and gender considerations need to be taken into account in all these aspects. Also, sometimes you're designing a study that you need to gather information about the follow-up time, and you need to define a follow-up time. So in follow-up studies, you define a follow-up time to answer your research question. Now, my question is, should the duration of this follow-up time be defined by considerations of sex and gender? What do you think? We'll go back to the example of heart failure. I showed you that if you want to look at the 5-year cumulative risk of heart failure for men and women, the risk varies substantially. But if you want to look at the long-term or lifetime risk of heart failure, that is the probability that each single individual at any given age, for example, the age of 50, will develop heart failure for the remaining of their lifespan, then the risk is almost equal for men and women. So there should be sex and gender considerations in the way you define the follow-up times for your study. This is also very visible in the task force charts that defines the risk of cardiovascular disease or coronary heart disease, and you can find it normally in every general practitioner and cardiology practice office that shows clearly how the distribution of risk in men and women differs by the age and also by the follow-up time, if you look at 5-year risk, for example, or 10-year risk or lifetime risk. So, another topic that comes into consideration when you're talking about data collection is the sample size consideration. So what is the sample size you need to arrive at robust, let's say, estimates when you're looking at sex and gender differences in your data? Normally, we say we should at least have 70 to 80% statistical power to detect the effect in our data that we're interested in. So, for example, an association between an exposure and a disease. How about exploring sex and gender differences? When it comes to sex and gender differences, if you look into the literature, you see most of the studies are powered enough to look at that main effect of interest between the exposure and the outcome. And a lot of studies are underpowered to examine the associations in men and women separately, unless they have planned it in advance. This is particularly true when you're using the existing databases to look into sex and gender differences. Have in mind that those studies might be powered enough for the main research question, but they have not been designed and powered to look at also sex and gender differences. If you don't take into account the fact that you're underpowered in many studies to look at the differences, you might draw premature conclusions about sex and gender differences in your dataset. So you might arrive at conclusions about simply the differences that do not exist because you lacked the power, the statistical power, to find these differences. So what does this statistical power depend on? If you're interested to find sex and gender differences in your data, differences between men and women, let's say, broadly, in your data, what does your statistical power depend on? Two factors actually determine that statistical power and sample size consideration. One is prevalence of exposure and outcome among both men and women in your study. And the other one is, if you're looking at the association of X and Y, the strength of the association between that X and Y in men and women. Where do you get that information? Normally from the literature. So if you want to do a study on a specific exposure and outcome, normally you go and study about it. And you look at the body of evidence that already exists about that association or about that specific outcome, and you try to come up with estimates based on the available literature that what would you expect for prevalence of exposure and outcome and for the strength of association in your data. Even if the direct research question under study, you cannot find it, you get some indications from the available literature on how to approach it. And there are many statistical softwares that you can input a range of possible main effects and interactions that you expect, and again, then it gives you the impact of sample size on your ability to detect sex and gender differences. But overall, you need a larger sample size to arrive at sex and gender differences. So you need a larger sample size for making robust conclusions regarding sex and gender differences in your data that you need for answering your main effect in your data. And you need to be aware of that. A rule of thumb says you need about 2 to 4 times larger sample size to detect sex and gender differences in your data. So don't underestimate it. Lots of studies are underpowered to arrive at robust estimates. What do you do if your study is underpowered? You just accept it. Don't overrate your results. Don't make underground inferences. Don't make the literature full of all of those inconsistent findings. It applies to all of us. Make sure your data supports what you are reporting. And if you don't have a luxury to have a large enough data set to arrive at robust estimates for sex and gender differences, try to make your results available for others to read. Don't overrate your results, but make it available. In the journals, you normally can present the results in supplementary material, for example. So your results may help the others. They might be the starting point for the others, the starting point of the analysis for future studies that might be adequately powered to answer this specific research question about sex and gender differences. Now, we discussed the issue of being underpowered in many studies to arrive at robust sex and gender differences. And more, increasingly large data sets are becoming available. For that, a lot of them are also publicly available. What we know nowadays as big data. So is this big data ultimate answer to perform sex and gender analysis in your research? Think about it, and we'll get back to this in the third series of this lecture.
Thank you, Maryam. We talk now with the two researchers, Lieza and Jeanine, about their research and their populations and data collection. Jeanine, Maryam already told it's not necessary to have 50% man, 50% female. Did you ever do a research on a specific female group?
Well, thank you. Yes, indeed. I'm still doing the cycle study. And that's a study that specifically looks at the phases of the menstrual cycle and its influence on cardiac symptoms.
Was that ever done before?
No. Yeah, well, actually, that's very interesting because I really wanted to do this research also because, what the feedback was in the clinic and that women really experienced at specific periods of the menstrual cycle palpitations or also chest pain. And then I wanted to do more research on this subject. And actually what I found also is that it was still a taboo to do research, to talk about the menstrual cycle and to do research about it.
And how did you define your population? Because, for instance, did you had phases in age?
Yeah, well, I mean, for this research project, it was important to really define that we wanted, because we wanted to study the influence of the menstrual cycle. So we wanted to collect people, that sounds a bit too harsh, to include women who had a regular menstrual cycle. And to ask them, and we had an app that was really beautifully designed, and ask them, when is your menstruation starting and when do you have cardiac complaints? And I discussed with Maryam, how can you really, what's the optimal study design to do such research, because you're actually using women as their own controls. Am I right, Maryam?
Yeah, exactly. So I think I mentioned in the first part of the lectures that probably the choice of your study design might not that much matter with regard to sex and gender considerations, and the research question should guide you. And this specific question, for example, where the research question about is about the phase in the menstrual cycle where you experience palpitations, for example. We had a beautiful discussion, and I think one of the designs, for example, that might be most relevant here is a case crossover design where every woman acts as their own control. So you look at exactly the phase before the event, in this case palpitation, and you look which phase women were in when they had this experience of this specific event, the palpitation.
Yeah. Okay.
And so every woman acts as their own control. It's a beautiful design, for example, when you want to answer such questions.
And Jeanine, do you think it's necessary that you look also in for men in the same life ages, in the same age groups, to make a comparison?
Well, it also
in the end, of course.
It really depends on their on the research question. So, for example, in this case, you could either use women who are postmenopausal, who do not have a cycle, as controls, or you can use men as controls. But I think that well, what we said, it's important to really look like what is the research question and what variable are you looking at? And as men do not have a menstrual cycle, it's very simple. So
you say, no, I don't have to do that.
I don't have to use men in this study. So well, we, sorry for that, but we ignored men. This is a specific question for women. And maybe also, what I also study is the long-term effects of hypertensive disorders of pregnancy. So women who had gestational hypertension or preeclampsia during pregnancy, we know now that it's not a matter only of a complication in pregnancy and for pregnancy outcomes, but also that it has long-term effects on developing cardiovascular disease and
also
hypertension.
at an elderly stage.
At an elderly stage. So there, what Maryam mentioned is also like what's your timeline and how long are you looking for it? If you only look at the pregnancy outcomes, you miss those long-term effects.
Yeah. Lieza, if you look at your research, did you do specific research on a specific group?
I didn't do any research yet on a specific group, but when we're talking about these specific risk factors for men and women, or I wonder, because we're always talking about menstrual cycles and pregnancy, but I do have a lot of questions still, and they're more gender related, because is it really the pregnancy, or maybe also more the having of children, having a family, social interactions? There's not a lot of research in that field, but there's some studies showing that having children is a little bit protective. But over 6, I think, isn't protective anymore. I think there's a lot of research needed in that field as well, and not only looking at the biology, but also about the gender aspects. Of these differences.
And if you look at your research field, what triggers you to do if it comes to gender?
If it comes to gender, I think that as a clinician, we are not paying a lot of attention yet to sex and gender, but I think there's a lot of clues going on that we might have to ask about.
Can you give some clues?
Well, I think so. For gender, it's still difficult. But for instance, in men, we also know that erectile dysfunction is a risk factor for cardiovascular disease, but we never ask about it.
So you say I have to do, for instance, a research purely on male populations.
Well, I think that could be interesting. Yes.
Yeah. Why isn't that done yet?
Well, I think it also has to do with what Jeanine is telling, that there are some topics that we're not really open about. Even like clinicians ask a lot of their patients, but still asking about erectile dysfunction, for instance, could be awkward or be felt awkward to ask about. Menstrual cycle also is not asked about. So I think there's also
because
some
of the intimacy.
Yeah.
Because of the intimacy, scientists do a step back.
Yes, I think so.
Oh, interesting. Interesting to hear.
Yeah, even in
because
the Western
everybody
world.
is curious in science. So I think that's a normal question, isn't it?
No, but there's some taboos, and I think it's good to mention it and to really label it as taboos, because then you can break through.
Miriam, how do we do that to make a breakthrough,
Well,
especially to do very good research and define a very good population for your research?
Yeah, I think we should think about it carefully beforehand. And what I hear here is really interesting that we talked about gender and sex differences, and a lot of examples come from women. We talked about menstrual cycles, menopause, and all of the hormones, but we have to realize also that there are men also here, and we need to study also the factors affecting men, and it's not all about women. It's interesting to look at, as I mentioned, similarities and differences. It gives us new hypotheses. It gives us, it enlightens us into the underlying pathophysiology. So it's not about men and women. It's about the good science, and we have to think about it beforehand to gather all the information in a very informed manner to allow us later to look at all similarities and differences between the sexes and the genders.
Yeah, and Lieza, if you what Maryam also told us, there is a danger of premature conclusions if you have only certain data. How do you deal if you do a research and have only a small part of the puzzle?
Well, I think also what Maryam said is acknowledge it. Acknowledge your limitations and describe what is the limitation and what needs to be done in the future. Because, for instance, I'm interested in stroke, and we know that after menopause, the risk increases for women to have a stroke, but also the type of stroke differs a little bit. So if you have data that doesn't have a long enough follow-up to see how that differs, acknowledge it, describe that it is a limitation. I think that's the best you can do.
So we need disaggregated data also for a follow-up study.
Definitely. Always, if you don't have enough power or if there's a limitation in follow-up, describe it, but also show what you do have so somebody else can continue with the work.
Maybe I can add something to that, and that's very interesting that you mention it. A couple of years ago, I performed a meta-analysis to look at the cardiovascular disease risks in women who had premature ovarian insufficiency. So they had a menopause before the age of 40 years. And what we found was that they had a modest increase of cardiovascular disease later in life, also of ischemic heart disease. But when we looked at stroke, we could not find an increased risk. And actually what we thought, and we described it because we didn't know for sure, is that as women those women were 40 when they experienced menopause or even younger. And we suspected that the follow-up time was not enough for those women to develop stroke, because we know that stroke is the last form of cardiovascular diseases that you develop during lifetime.
Yeah. So we need a follow-up of that study.
Exactly, yeah. But that was also existing data. And it really requires that you have a long enough follow-up, especially for diseases like stroke, which occur really later in life, but also for dementia, for example.
So the accuracy of data is very important. And that will be the next lecture of Maryam. Research design and the accuracy of data.